Good afternoon, bonjour. Cet après-midi, on discute.
This afternoon, we will be talking about abortion. This is a discussion that we have a lot in Canada.
It is stunning how much stigma still surrounds it in the year 2017. Witness the fact that your printed paper does not say the word abortion. It says sexual health services. We will never overcome stigma. We will never overcome fear if we don't have the discussions ourselves and if we don't take those discussions publicly. To put some context, it is estimated that in Canada, 1 pregnancy in 5 ends in a medical termination and termination of pregnancy. In a recent survey that we did at the Society of Obstetricians and Gynecologists of Canada, 60% of Canadian women said that they had had an unplanned pregnancy. 50% of women use birth control in the month in which they become pregnant. So think about that. You have a chance every time that you have intercourse of getting pregnant. If you have intercourse, say, twice a week for a year, that's 100 chances. If you're 99% accurate in your birth control, you'll have an unplanned pregnancy that year. So it's not something that women need to feel, what did I do wrong? I got pregnant. There is always a chance of pregnancy. And the problem is that pregnancy at the wrong time can have devastating health consequences. So we're very pleased to have the attention of this wonderful panel who will discuss some of the context and some of the challenges and some of the potential solutions to improving access to abortion worldwide. So what we'll be doing for the format, I'll be introducing our panelists. I'll be giving you some background. We'll do some probing of their answers on a couple of questions, and then we'll be opening up to your questions. We will ask you to, we'll take as many questions as we possibly can, ask the panelists to respond to as many of those as we can, and hope to still maintain strictly on time. Thanks very much. Okay. So our first speaker is Sabine Barnach. So Sabine, would you like to tell us a little bit about yourself and just give us a little bit of overview on the work that you do and some of the challenges and solutions that you see?
Hi everyone, my name is Sabine Barnach. I work as a reproductive health advisor in emergencies for Save the Children. I brought you a few slides just to provide you with a bit of a snapshot of our work we do at Save the Children on family planning and post-abortion care in emergencies. At Save the Children, we strive to include sexual reproductive health in all our acute emergencies. Regardless if we are responding to an acute emergency or a protracted crisis, we can see the crisis itself through the eyes of a child and adolescents. And that, I think, puts us at a very unique position to address those special needs that adolescents are facing, particularly in regards to sexual reproductive health. As we all know, in humanitarian contexts, in context of conflict or crisis, health systems are often disrupted and access to life-saving care, particularly for sexual reproductive health, are not available, particularly if you're an adolescent girl. Simultaneously, we are all aware of that. Women and girls are particularly vulnerable and at an increased risk to suffer from reproductive health needs, suffer from unwanted pregnancy, sexual violence, and complications during pregnancy and childbirth. 60% of maternal deaths globally are taking place in humanitarian contexts. Every year, there are around 44 million abortions taking place, with almost half of them due to unsafe abortion. We also know that 222 million women and girls are at an unmet need for contraception globally. Nevertheless, also the need obviously exists, particularly in humanitarian contexts. Often family planning and post-abortion care, two key strategies to counteract some of these SRH needs, are often not addressed in humanitarian responses. At Save the Children, we've been implementing family planning and post-abortion care programs with the particular design that you see here illustrated on that slide, and I'm not going through the details. But since 2012, we've been implementing such programs in a number of countries. Over the years, we have optimized our project design, scaled up and expanded the program. We started in Darfur, then moved to Pakistan. We are now in DRC, in Yemen, in Somalia, in Syria, in Niger, and in Egypt. I hope I didn't forget any. But you can see the variety of the context and also the various challenges that that are faced in these contexts. I want to give you the example of Somalia, where, and you will just see some pictures here. In Somalia, we've been partnering with the Ministry of Health and implementing contraceptive services, but also post-abortion care in these facilities. And I just want to highlight here the post-abortion care component of the program, because post-abortion care has previously not been available to the target population of over 200,000 men and women. So any woman or girl suffering from an abortion didn't have any access to life-saving intervention. We implemented post-abortion care through manual vacuum aspiration and misoprostol. Those are two alternative treatment options that are also recommended by the WHO. Implemented it in the region, in the operational area where we implemented, and made it available. And just to share how successful such a program can be, when we started back in 2012, we saw in the whole region around 11 cases per month, and we are now seeing over 100 cases. And I'm just sharing this result that beside of all the challenges we are facing, even in a very challenging context like Somalia, these interventions are absolutely feasible to implement. I would have liked to share a few more examples from how we partnered with the ministry in regards to the service provision, or also what kind of community activities we implemented to create the demand. But maybe we keep that for later. Yeah.
Thank you very much. And now we'll move on to Mirta. Olivares Bonilla, who is from International Planned Parenthood Federation. She is a youth speaker from Puerto Rico, and if you could pass the, do you need
No,
no, you're
it's
good?
okay.
Okay.
So thank you so much. I'm so honored to be here with you. Saluda a tu mon, yo le digo Andy.
Hello, everybody.
I'm Mirta Olivares. I'm the youth representative of Pro Familias, Puerto Rico. Also, I see International Planned Parenthood Federation. Pro Familias, we all know, is a Planned Parenthood member association. I am part of Pro Familias since I'm 11 years old. As part of this experience, I have the opportunity to be part of the sexual education project that's working with young people. And in this opportunity, I have the opportunity to exchange information about sexual and reproductive rights, abortion, stigma, contraception, prevention, among other topics. Currently, I'm part of the board of directors of Pro Familia, representing the youth sector. In my position, I continue to advocate for the young and sexual reproductive rights, as well as ensuring that our programs are facing and responding to the realities and needs of the young people in Puerto Rico. Since 2010, Pro Familias has the Clínica Ella that's offering surgical and medical abortion, as well as gynecological services. We have an educational project that includes the team in an inclusive way in the sexual and reproductive rights health. And we have also an exclusive team that is Let's Talk About Abortion. On the other hand, in the centers of distribution of the country, we also bring services and guidance to those who refer people to those who need them. In Puerto Rico, right now, there are 7 private clinics, which Pro Familia is the only one non-profit organization that's taking in mind the participants' income and the family composition. We have also 2 educational projects taking young education, peer education as base. And we also offer training to medical and law students in different university centers of the country. And we are ensuring now how we can be more inclusive and how we can impact the young people through social network and how we can disseminate the information. We believe that these are key important issues and networks that we can do with other young people, not just in Latin America, in the Caribbean, but also globally. So I'm so happy that I have been seeing from El Salvador, Guatemala, Mexico, and Peru, I have been seeing around. So I'm so happy that you're here.
Thank you, Mirta. And then our third panelist today is Sandeep Prasad, who is the Executive Director of Action Canada for Sexual Health and Rights. Sandeep.
Thank you very much, and it's a great pleasure to be with this great group of panelists and with all of you this afternoon. I'm just going to say a few words about Action Canada for Sexual Health and Rights, just to orient you to, I guess, my later comments in this session. Action Canada for Sexual Health and Rights is an organization based in Ottawa that seeks to advance and uphold sexual and reproductive health and rights both in Canada and globally, and seeks to be a strong voice on those issues, both at home and abroad. We do a mixture of work. So domestically, we do health promotion work, and we do policy work as well. In terms of, just as an example of some of the health promotion work we do, we're currently finishing off and getting ready for publication, teacher supports for comprehensive sexuality education programs in schools in Canada. And that resource support will be released later this summer, in August. If you want more information, I do have pamphlets about that here, and you're welcome to those. In terms of our global work, we are the secretariat of a global coalition known as the Sexual Rights Initiative, and over the last 10 years, we have been working to build this coalition that is explicitly feminist in its orientation, its political orientation, and ways of working, and is Global South and Global North in its membership. And the Global South members are double the number of the Global North members. We are all national and regional organizations, and we come together for focused work around the UN human rights system, both in terms of advancing global policy on sexual and reproductive rights issues, but also working with countless partners, sexual and reproductive rights defenders in many different countries. We work to help them harness the global accountability mechanisms in order to advance their national priorities within their countries as advocates. So part of that work includes the production of tools and databases to support that work. You may already know about, and you may be quite curious about, our sexual rights law and policy database, which seeks to look at laws and policies that impact the realization of sexual and reproductive rights across a wide variety of domains. And you'll see, actually, we have quite a section on legal and law and policy restrictions related to adolescents, looking both at, for example, spousal consent requirements, parental consent requirements, marriage requirements to access services, and all of that you can find on a publicly available database. I have pens here. I'm just going to do this Oprah style. You get a pen and you get a pen, but there are far too many of you to do that. So some pens for you who are really keen about this up here. Thank you.
That's great. So you can see we've got a really diverse and panel with a wealth of experience. I'm going to just ask a few questions, and I'm going to ask you to be very brief in your answers because we're being asked to be careful of time. So Sabina, you're very involved in post-abortion care. It saves lives. Can you tell us about manual vacuum aspiration and misoprostol in humanitarian context and why it's so important to ensure that we have PAC in those settings?
In most fragile states, or in contexts where we work with through humanitarian responses, what we often find that post-abortion care is not available, or if it is available, then it's limited to dilatation and curettage, which is a small surgical procedure provided by doctors that is only available at hospital level. So a little bit of an infrastructure needed to provide these services. As I said, in humanitarian context, normally the healthcare system are disrupted and access is really an issue. Through the implementation of MVA and misoprostol, both, as I said, alternative treatment options that are also recommended by the WHO, these services can be brought to a lower level of care, to a primary health care center, and can also be performed by mid-level service providers like nurses or midwives that do the bulk of SRH services in crisis context anyhow. So that can push availability of abortion care tremendously and potentially save a lot of lives. That's why for our work in humanitarian context, this is really essential.
Excellent, and I agree. They're very safe procedures. Mirta, how are we going to improve access to safe abortion for young people in Latin America and the Caribbean?
Latin America right now is home to the more restrictive laws about abortion in all the world. So taking that in mind, Latin America and the Caribbean are facing different contexts in each country. What we have to say is that restrictive laws do not stop women from having abortion. And on the other hand, legality is never enough because Puerto Rico is legal, but in all the countries, in most of the countries of the region, what we are facing is a stigma barrier. So in order to make access and guarantee access to those services, we have to work with it and to help to prevent and to clarify the myth. Stigma and fear and shame can affect pregnant persons to seek and to ask and to search that support and that services. And that's one of the most stigma barriers that are facing young people, at least in Puerto Rico, is that they think that they will not receive the correct support that they need. So in order of that, we can see that stigma has different levels. That is the individual, the part of the community, also in the institutions, the part of the legality, the government structures, as well as the mass media and culture and the way we perpetuate language. What we have to say is that either way, what is legal in any country is to share information, to talk about abortion. So in the countries where it is not legal, that's our best ally, to talk information and to make access to that. What is important, another thing, is the strong economic situation that are facing women and persons living in Latin America and the Caribbean. Poor women are less likely than other women to have access to those services. And that put them at a higher risk of complications and prosecution from clandestine procedures. Also, young people are less likely than other women to have access to this. And these are because of young women autonomy, because of stigma, because legislations and on laws according of sexual and reproductive health rights, as well as disinformation. So we think that information has to be key in our services. So young people need that information to make better decisions, be more empowered about their sexuality, their body, and their citizenship. So we encourage to put in base comprehensive sexuality education because we believe that comprehensive sexuality education should help young people to access to that information, acquire information that they need, and also dispel the myth that are around the theme. Also, it reference to the services that they are. Also, it make leadership, and one important thing, it does broke the most dangerous stigma barrier, that is silence. So the comprehensive sexuality education, in the comprehensive sexuality education, young people tend to be more open about their situation, tend to be and share more about the situation with young peers, as well as with their communities, with their parents, with others as well. So that's one, and they also tend to be more inclusive about the needs of other young people. So we encourage people to think or to question if we really have stepped into the shoes of those who have had an abortion, or those even think about having an abortion. Also to those who support access to safe and legal abortion. We think that this reflection challenges abortion stigma related to abortion, safe and legal abortion services. As well, it could be also implemented in sexual and reproductive health rights in general, because it makes an empathy regardless of gender, race, gender identity, nationality, or sexual orientation. So we may think, or we don't see it, but a step forward into empathy to the other person, to the other human being, we may not see it, but can be a big step to those who need that services, especially young persons.
So break the stigma, information, empathy. Sandeep, you've described a role in advocacy. We suspect you're finding it's a very interesting political climate these days. How would you describe the global political climate, and particularly as it relates to adolescent sexuality and access to abortion?
Absolutely, thank you. So despite the fact that all policymakers were adolescents at one point in their life, adolescent sexuality remains taboo across all regions, really. And these taboos are really rooted in entrenched gender norms, as we've been as we've been hearing over the last many sessions. And these become manifested in many ways, including in laws and policies restricting access to services, information, commodities, and education, including and especially related to safe abortion. The protectionist and patriarchal lens that is applied to adolescent sexuality is not grounded in human rights or reality, and actually has lethal outcomes. And you know, the shocking evidence that we hear about child early and forced marriages, HIV infections, sexual violence among adolescents, all of these shocking outcomes are still, in many cases, not enough to sway many political leaders to talk openly about the root causes and the underlying factors behind these human rights violations, and that is being exacerbated now by the rise of nationalism and fundamentalism throughout the world. There's a corresponding with that rise, there's a corresponding shrinking of civil society space in many countries, and sexual and reproductive rights defenders are often amongst the most targeted, are often at the forefront of being targeted under the guise often of traditional values or morality. And of course that has a disproportionate impact on women and girls, and affects all aspects of their lives. We have to just look across the border to really see that clearly in action. So in short, the global political environment for adolescent sexual and reproductive rights is complicated, challenging, and sorely missing the voices and participation of young people. But it's always important to remember that sexual and reproductive rights have always faced heated opposition. The actors and methods may have changed, but we should never underestimate the determination of people to stand up and fight for rights. And that we should never forget that we have also made tremendous progress. I know that Flavia went over many of the contributions of the human rights system, and you know, we could list many, many more of those within the session. I won't here, but all of those are moving towards greater recognition of the universality of adolescents' rights, and particularly their sexual and reproductive rights. And coupled with that, we see just within countries themselves a global trend post, the ICPD program of action of liberalization of abortion laws, and the countries liberalizing abortion laws versus making them more restrictive actually outnumber, they're greater by about tenfold. Another example of that really informs our political climate is the She Decides initiative, and I think that's a great example of resilience that's happening right now. As one state has made a very clear attack on abortion rights, we see many who are speaking out and just very sharply bringing to focus the impacts of those policies, but also bringing the focus back to women's and girls' rights to bodily autonomy, and that's quite critical.
I think that's a really important context, and for those of us in North America, we may lose track of the real successes that are being made, and the countries that are now saying they rarely see a maternal death from abortion, which is ultimately our goal. I'm going to do one super quick round for another question, so ask you to be very brief, because we do want to hear from the participants here. So Sabina, you've implemented a post-abortion care program successfully in humanitarian context. Can you tell us about some of the key challenges and a solution that you found?
I mean, obviously there are a lot of challenges, and I think we talked about it quite a lot. There are a lot of contextual challenges in any kind of humanitarian response, but then there are also the issues around availability of qualified health workers, availability of medical supplies and equipment, and so on. The short answer would be there's a really, really good toolkit that was developed quite a few years ago. So in collaboration by Save the Children, in collaboration with UNFPA, I think it's a really good toolkit that can guide implementation. I think the bottom line that I want to emphasize as an answer, there are solutions to all these challenges. So it's regardless if it's a lack of trained health workers, cultural barriers, what we learned in Somalia and a lot of the other contexts we worked in, that there are strategies that we can apply, and most of us are very creative, especially in collaboration with the people that are working on the ground, to come up with really, really good initiatives and solutions. So yeah, I think most of these challenges are really solvable.
So collaborate, listen to the people on the ground, and use a proven toolkit. Don't try and reinvent the wheel. Would that be fair?
Yeah.
Excellent. Mirta, we have been hearing a lot about Zika. It's been heartbreaking to hear this, but imagine even more so in the context that it's being experienced. Can you just tell us how Zika has affected sexual and reproductive health in your region?
Well, Zika, for us and in our region, has highlighted a social, economical gap and inequalities that exist in the region, in Latin America and the Caribbean, that includes Puerto Rico. In our case, again, the women, the persons most affected are the women, the poor women that lives in poverty and that already have difficulties accessing to this contraceptive service. So in order of that, we as a institution, we try to overcome these social inequalities to make more near and to provide access to a full range of sexual and reproductive health services. That's including safe abortion, and also support, social support for women that need this, and families with children related with Zika conditions. In our case, we noticed that people did not know about the situation of the virus, even before they don't link that it can be also transmitted sexually. So at the same time, the presence of virus can make an impact on our situation, perpetuate in the way it was perpetrated in the outsiders of the Zika zone. We can say that, as known by Leira Pajín, she's the development director of the Institute of Global Health in Spain. She noticed in surrounding what is Latin America and the Caribbean that it's better to prevent Zika than to cure it. So we make an effort in the part of the prevention and the information about the virus, especially to young persons.
So really saying we have to think about the whole problem. We keep on coming back to the SDGs, don't we? And Sandeep, I can't resist the call to action. What is needed in terms of advocacy to address this topic, adolescent sexual rights, including abortion rights, now?
Well, sometimes it takes a jolt of certain proportions to realize that even if women and girls in the world could wait out the global gag rule, it will just happen again, and we must act now to stop that cycle. And that's why I think the She Decides initiative is particularly important. I had the pleasure of joining Minister Bibeau on the delegation to She Decides in Brussels. And what was great was, and quite electric, was to see 50 governments there all really talking about issues of women's and girls' bodily autonomy, and talking in very strong terms about that. And what was promised at that conference was really that this isn't just an event, this is the start of a global movement. And that global movement, as I would see it, is one where we're centering and grounding ourselves in principles of autonomy and empowerment. And we are seeing leaders at the highest level really as the champions of those issues, and really seeing that leadership at the top political levels, which has been missing for a long time. And so building upon that, that could take the form of some sort of, interministerial group that, remains closely engaged around these issues and moving them forward, or some sort of high-level panel of some sort that does that. And I would suggest that it can't just be about funding. It really has to be, and it can't just be about the UN, but it has to be about interlinked advocacy at local, regional, and global levels. Because really, what we're in the SDG era, we're seeing just the creation of regional accountability mechanisms. And we're seeing the importance of national accountability mechanisms taking shape. And so really, that advocacy needs to be present at all of those levels, and it needs to be championed by ministers, political leaders. Thanks.
Okay, well, thank you very much to the panel for giving us a good grounding of this. Would everyone like to just stand up and get some air? They say sitting is the new smoking, right? So I'll get everyone. And while some of you are on your feet, would you like to go and assemble by the microphones for your questions? And if you don't have a question, you're welcome to sit back down, having had a bit of a stretch. And what I'm going to do is let you ask your questions. I've asked the panelists to take notes, but I want everyone to have a chance to have their question asked. So we'll just go around and get the questions out. We'll then pause after a few questions and let the panelists tackle some of your questions. Then we'll see if we can get back to the floor. So starting over here. If you could introduce yourself and pose your question.
Hi, Stephanie from Population Media Center. I think my question's an inevitable one. In light of the global gag rule and the recent expansion into PEPFAR funding as well, the European donors have come together and contributed a great deal in working together to try to overcome that hole, but it won't be enough. So what can we do, and what must we do to work together, whether it's UNFPA, IPPF, SAVE, and Marie Stopes, the organizations that really have that global scope, to make sure we provide information to all the women and girls so that they know on a country-by-country basis where they can obtain abortions, because there's going to be that hole, and there's no way to undo it now. So what can we do to make sure that we get them to where they need to go?
Thank you. Microphone number 2.
Hi, I'm Nicole Kineski. I'm a youth advocate with Plan International Canada, and I attend a Catholic all-girls high school currently, so I was wondering, what are some strategies and respectful ways to start a conversation on comprehensive sexual education and to advocate for access to safe abortion and for women's right to autonomy over their bodies as a young person in such a conservative environment? Thanks.
Thank you very much. Back over here.
Hi, my name is Jennifer. I work with an organization called Ethiopia Aid Canada, and my question is for Sabine. I'm wondering if you could expand on your collaboration with the Ministry of Health in Somalia to talk about how you ended up implementing your work, and perhaps it could inform our work as well.
Okay, so it sounds like a question for Sabina, a question for Mirta, and a question for Sandeep that we've heard so far. Why don't we take those 3, and then I'll come back to the mics.
Okay, maybe I start to, it's also a nice example. What we probably all know from Somalia, and it's often quoted in a lot of reports on maternal mortality and so on, it is one of the worst cases to be a mother. I think they have a maternal mortality ratio of over 700 and a contraceptive prevalence of 3%. Fertility rate, I think, is around 6 or 7. So really harsh conditions. We implemented the program obviously because there was a great need. The collaboration with the government in its Puntland in the north of Somalia has been extremely positive, very, very fruitful. Bottom line, we have to admit that they don't have the capacity technically, but also financially, to put into practice any of their commitments. So the collaboration in general was pretty good. We have a very close partnership with them. Just to give you a few examples to address some of the challenges, in the beginning, we had to fly health workers to Kenya for training purposes, and similar, we partnered there with Mary Stopes International. And after a few years, we're able to start setting up a training center that is by now running for a couple of years, that the Ministry of Health itself is running. They are using the training center for a lot of their sexual reproductive health trainings in Puntland and also in the neighboring Somaliland. They have a strong commitment to put these things into practice, very, very keen to scale up our program. Again, they are lacking the resources, but the willingness and the awareness is really there. And just to give you another example, as we are often...
I think we'll leave it to one example just so that we can... More discussion in the hallways after. Mirta, how to introduce education in the Catholic
I
school.
understand was comprehensive sexual education and women autonomy and advocacy, right? Okay, we have different guidelines. It depends on, it goes to peer education, if you are a young woman, sharing information with other young people, also to the training and medical students. So we have different guidelines for every person and every involved in the situation. What we believe is that comprehensive sexual education form the young people, if it's from younger age, is better because at younger age you are receiving all that input and you are receiving all the information that makes you and are forming you to have better knowledge about your own autonomy, about your rights, about your leadership. So it helps to create leaders in order that they guarantee also their citizenship and they can share their voice about what is their needs, what is the things that matter to them.
Unleashing the power of the generation.
Huh?
Unleashing the power of the generation.
Right, yeah. We are trying to, as APPF, to make a way to be more, how do I say, more close to the that gender gap and global policies of every woman, every child, to all the politics of UNESCO and also related to young people.
Thank you. Thank you. And Sandeep, yours was on life after the gag rule.
Sorry?
Yours was on the impact of the gag rule and how and where we go from here.
Absolutely. And I will take a stab at that question, but I want to talk about something specifically because I think it relates to what She Decides needs to be teaching us as a movement, and really what I see as a test case coming up, so months after this, the launch of this, what was promised as a global movement around issues of bodily autonomy, is really the London Family Planning Summit in July. And what we saw, what I'm looking for, and what I think many of us are looking for, is have the main actors involved in the London Family Planning Summit, what have been the lessons learned, and how are things going to be different in 2017? Looking at what happened in 2012. In 2012, there was actually a fair bit of opposition from feminist organizations, including my own organization, to how things unfolded, where there was, in our view, lip service paid to issues of bodily autonomy and empowerment, and really those principles not being centered in the approach. So, really abortion was siloed and hived off from the discussions there. We actually didn't see agency and autonomy being really centered within the approach. There was really no grappling with contraceptive failure other than really to talk about low failure methods, right? And to prioritize low failure methods. And instead of really looking at expanding choices within contraceptive access. And demand was not prioritized. It was really market-driven commodity approaches taken. And is that going to change in 2017? Following She Decides? I think that is a big question for me, and that's a big question for our community.
Okay. Yeah. Is there a burning question that someone really wants to make sure is heard? Yes.
Hi, thanks to everyone. My name is Michelle Monroe. I'm a consultant in health and reproductive health, and I also work in abortion care in Ottawa. So my question is, this is CanWatch, and we haven't heard about Canada and how any of us are going, as far as we've got so far today is PAC. Nobody's talked about abortion care yet. We've got to post-abortion care. So we've obviously got a long way to go. So I'd just sort of like to hear what the next steps are for Canadian organizations, both to get involved, but also to develop an expertise in developing countries, because not very many of our projects include abortion as part of their choices. So that's my question.
I think that's a very important issue. In fact, abortion is included in some of the projects that are ongoing, and I'd be happy to talk to you about some of that work. But it is there, and it has to be. Yes.
Hi. So I just have a question about advocacy approaches, because right now we have a situation where there's lots of advocacy around policies and laws, which is so important for governments to recognize a responsibility towards providing abortions that's safe and accessible. But there's also this other area where because medical abortion can now be accessed online, so you have other organizations that are going around and saying, we'll let you deal with the policy legal side of things, but people need these medications right now. So you have Women on Web and Women Help Women. So you have these organizations, and there's research as well that people, some people do prefer to have their own private, what do they call it? Self-managed abortion is the official term that they use. So when looking at the policy legal side of things, how do you advocate for that without stigmatizing people that are choosing to have self-managed abortion, or because they have no other option are doing a self-managed abortion but that it is still accessed in a safe way?
I think it's a really important issue because you don't want to, and Sandeep, I don't know if you want to do this, but and Canada's very late to the table with access to medical abortion, but you don't want to remove choices that women have, and women do have real preferences as to whether or not it's a medical or a surgical procedure and how they approach that. Do you want to add to that? Or? No?
No, I think there can be viably, a multiplicity of approaches. I mean, I think, there's a lot of good work happening in terms of community access to misoprostol, and not just the mail order services or that sort of supply, but also just access within communities, even in restrictive contexts. And for me, I don't know why there can't be a multiplicity of approaches pursued in given contexts.
I think that we're actually at the end of our time. Very sorry, but the panelists will be around, and there's a networking break coming up. We have 35 seconds. Do you have 2 words that you want to each add? 1 word, 2 words? Okay. Shout it out.
Maybe I have one closing remark to share, at least from an emergency point of view. And I like the question that came up, that we talked about post-abortion care. I did definitely limit myself to post-abortion care, which I find very unfortunate. But anyhow, what I wanted to say is that from an emergency point of view, there's always
5 seconds.
Often a pushback that it's not feasible and not realistic to implement these services in an acute or protracted emergency response. I think we have the evidence base.
We're out. We're done. We're over time now. We're out of time. Really sorry I had to cut you off, but we promised that we would stay on time because the next breakout session starts promptly at 3:35. So it's time for your break now, and then you can come back to your sessions. Thank you very much. There's clearly more to be said than could be said in this time.